Hey there, folks. I'm Eric Osberg, and I'm the Rural Rebound Initiative Coordinator for Otter Tail County. And we're back with another Better Together segment. And today we have an expert with us. We have Dr. Ben Hess from Tri-County Healthcare. Dr. Hess, thanks for taking some time to chat with us.
Thanks for having me, Eric.
How are you holding up?
I'm doing well. I'm at home coordinating a lot of things remotely, like a lot of people nowadays. So I'm getting used to that new normal right now.
And to give folks a little bit of your background, how long have you been at Tri-County Healthcare?
I've been with Tri-County Healthcare for about 10 years now. So I've been a family physician there for that entire time frame. I took on the chief medical operation or officer operation about 3 or 4 years ago now. So I've been splitting a role there for a little while now.
Gotcha. So we haven't normally done this in these conversations, but we sent you a list of questions because we wanted to give you some time to think about your answers, because these are technical answers, right? So the first question we have is, we've heard a lot that the flu kills more people than COVID-19. So why is there so much attention being paid to COVID-19? Why are we taking these extreme measures, if you will, when the flu may kill more people than this does?
That's a really good question, and there's a lot of detail and numbers behind that. So I'll kind of start with some of the basics. First of all, when you're talking about the number of deaths caused by COVID, we actually haven't seen that final number yet. In fact, we're really just starting to get an inkling of it in this country. So unfortunately, the death toll is going to continue to rise with COVID. So I don't know that it's true for very much longer that the influenza is going to kill more people than COVID. The other thing to look at, or maybe a better way to compare them, is to compare their fatality rate for each disease. And if you look at influenza, that rate is about 0.1% of all the cases are fatal. That's roughly 1 in 1,000. Okay. COVID has a percentage rate fatality that's across the board closer to about 3 or 4%. So that's about that's a magnitude of 10 higher there. So it is way more lethal, way more dangerous than influenza, first of all. Second of all, influenza has already some built-in mitigation efforts. We have a widespread vaccination program that significantly slows and delays the spread of the illness. It mutes the severity of the illness even when people do get influenza. And so our flu season stretches over a period of several months every year, and it does that slowly and gradually over time. But even still, in this area, in a normal year, we do at times run into max capacity in certain hospitals in their ICU beds, partly because of the complications from influenza. So even with those protective measures in place, we do run into some trouble there. And now we have a new disease that has no vaccination or no previous immunity built into the population to slow its spread. So if we didn't have the influenza vaccine available, you would actually see similar spread rate. It's an exponential spread rate, just like COVID.
So I guess the good news is there aren't many cases in this area right now, right? This seems to be, at the moment, it's a East Coast problem, or it's a metropolitan problem at the moment. So us here in rural Minnesota, should we be this worried about this? If so, why?
Yeah, I think this is really not easy to judge at the moment. Our testing capability has been so limited that we really don't know the true exposure anywhere. We are operating under the assumption that there is community spread happening right now in Minnesota, even in the rural areas. To what extent, we don't really have a finger on yet, but we know it's happening. The Minnesota Department of Health is releasing cases, and they're showing over a 30% community spread transmission rate right now of all the cases they identify. So that means a third of the cases are really happening just from unknown contacts, just picked up randomly in the community somewhere. And it is true that the East Coast and the metro areas are going to be hit first, and they're going to be hit harder because of all that extra traffic and the mobile population they deal with. But our time is coming, and it's going to roll out across the world eventually. So this is just as critical, just as dangerous of a time, because we can kind of get lulled into complacency right now.
And so you had mentioned the word capacity, testing capacity. Any idea on what the testing capacity is at Tri-County Healthcare right now?
Yeah, we have, it's a constant changing target here. So we have been trying to track down testing capability, testing equipment and supplies, and alternative labs that'll work with us, because everybody is scrambling to do this. That's one of the difficulties we have in a pandemic, is that everybody is trying to do this work at once. And so everybody gets inundated with requests and orders, and nobody can keep up with the supply. So, I hesitate to give you an exact number of our testing capability, because it literally changes day to day. But in general, at the moment, we have enough testing capability to follow the Minnesota Department of Health guidelines, follow the CDC guidelines as far as which patients we should be targeting for testing. So right now, that would be people that are hospitalized with COVID-like illness. That would be people that are healthcare workers exposed to COVID, so we don't, transmit that to new patients. And so we can identify them and send them home quickly. It's anybody that's coming from a care facility. So if they're in a nursing home, an assisted living facility, if they're in a group home, those types of facilities, we're testing them as well. And, finally, we do have enough testing to do some community maintenance and surveillance. So if somebody comes into our ER or our urgent care with suspicious symptoms, COVID-like symptoms, we do have the ability to test a number of them. We can't test everybody, and we're certainly not at a level where we can just screen people, and nor would that be effective. One of the main gray areas we have right now is that we don't actually know how precise our test is. We don't know what the false negative, false positive rate is. So we've done, as of yesterday, we've done over 80 tests right now, and they've all been negative. But that doesn't mean that those people are all cleared to negative. There's a very real possibility that several of those people still had COVID, and just the test did not identify it.
Any comment on bed capacity or ICU capacity? I mean, any thoughts on how many people? Because the reason I ask is, when we talk about flattening the curve, we're talking about capacity, right? Like there's a capacity level, at your facility in rural hospitals, and that's why flattening the curve is important, is because we don't want to cross capacity from a beds standpoint. Any thoughts on how many people Tri-County Healthcare could house if they needed?
Yeah, we've done a lot of work on that in the last month, I would say. That's been our primary focus. So in normal operations, we have a 25-bed critical access hospital. We have taken a close look at everything we have in our facility: supplies, staffing, available rooms, shutting down non-essential programs to open up more capacity. And what we've come to the conclusion is that we can increase that 25 beds to approximately 49 beds. We potentially have about 6 to 12 ICU level beds. We only have about 6 ventilators right now, and 2 of those we would be using mainly for transferring patients to bigger hospitals that are critically ill. So they're really just transport ventilators, not something we would keep somebody on long term. The factor here is that we have looked at some models, and that gets back to our earlier question about when is this going to roll out in the community here. Some of the models suggest that we're not even going to see very many cases until May, and that may extend even further out into the summer months, June, July, potentially, before we start seeing it flaring up and really increasing locally. On those models, when we look, that capacity I mentioned, that almost 50 beds and 12 ICUs and 6 ventilators, is about half of what we need. So we have flexed up to what we could potentially staff and what we have in our facility, but we won't be able to cover everything. And so as part of that planning process, we have entered into a regional plan with Centricare and some of the other surrounding hospital facilities. Centricare has also done similar work to shut down a lot of their non-essential programs, non-COVID related work, and they are trying to expand their ICU and COVID level of care dramatically. And so that means we'll be able to send more patients to them that are COVID illnesses. We'll probably have to keep more non-COVID illnesses in the community, and everybody will see a lot of shifting around. People are going to be moving to available beds and not always to the same level of care that they're used to or the same facilities they're used to in their normal transferring.
So what are the symptoms, right? Like what you've got influenza. How is this different from a symptom standpoint than say the flu?
I would say it'd be really difficult to distinguish the two illnesses just based on symptoms. We have a rapid test for influenza that also is has a fair amount of inaccuracy though, but really the symptoms are fairly similar. So most people have a high fever. Most people have a cough. Usually it's a dry cough. A lot of people get short of breath. They get muscle aches and pains. They get fatigue. They get some weakness with it. And the time course is fairly similar too. So influenza is usually a 7 to 10 day course. COVID is about a 7 to 14 day course. So it's going to be real difficult to distinguish based on that alone. What we do know though is that influenza cases are rapidly dropping off. So we're probably a month ago, we were seeing a number of influenza cases, and now that number has dropped off dramatically. And so now we're assuming that anybody that presents with those types of symptoms probably has COVID now, not influenza.
I'm sorry to ask how or why, but how does influenza, can you explain why the influenza cases have dropped off?
Yeah, that gets back to our natural mitigation efforts we already have in place for influenza. So the widespread vaccination program, actually the social isolation that we've been doing for COVID is also very effective for influenza. So inadvertently, we've been slowing down the spread of influenza. And because there are people that are vaccinated, that severely limits and severely restricts the spread of influenza in the community. So yeah, fortunately, that's maybe one good thing about this social distancing is that we've pretty much killed the influenza season early this year.
Right. Well, and so, and again, I don't know how much science we can get into here, but one theory I've heard is, COVID is a virus, right? Do I have that right?
Yes.
And a virus what I've heard is a virus isn't a living thing. And so that bodily fluids, whether it be mucus or whatever else, how is this is it possible for a virus to get transmitted from person to person through close contact, or how do viruses get spread, I guess is the question.
Yeah. So I'll answer the first part of your question. That's pretty quick, actually. So viruses would be considered a living thing in most circles. There was debate many years ago whether or not they were a living thing, but I think we're all in pretty much agreement now that viruses are a living thing and they can infect anybody. So that really isn't up for debate amongst any doctors or scientists. The transmission, though, is interesting and is a little counterintuitive for people. So coronavirus is transmitted by droplets. And so everybody thinks, immediately of things like sneezing and coughing, and, they assume that that's the main source there. And that's true. But what also happens is those droplets might happen from you rubbing your nose, rubbing your eyes, and then there is moisture that might have coronavirus in your fingers, on your hands. And then you go and you touch a surface, or you shake hands with somebody, or you rub your own face and infect yourself after you did that to somebody else. Talking, just the droplets that come out of your mouth from talking could be infectious in the right person, in the right situation. And so that's one of the reasons we're starting to encourage more mask usage to cut down on even that little bit. And that's one of the ideas behind the social distancing, that 6 feet is generally assumed to be the extent of how far a person can express droplets, at least in other viral illnesses. We don't know for sure yet the full range of coronavirus, but for most other viruses, when we say droplet precautions, that extends out 6 feet.
So is it possible that I could be, I don't know if the right word is carrier. Can people, if I have the virus and I don't have any symptoms, right? I don't feel sick. I don't have a fever. Is that possible that I could have the virus and I could spread it to others without any symptoms?
Yeah, in fact, that's probably the most infectious stage, actually. So that gets back to, good hand hygiene and avoiding crowds and, just taking care of where you're going and what you're doing even when you're feeling fine, because you don't know. The delay could be 48 hours. So you could feel fine for 48 hours and be spreading coronavirus throughout the entire community. So, that's always a good rule of thumb to ask yourself, okay, if I were to be diagnosed with COVID 2 days from now, have I been taking appropriate measures? Have I been acting responsibly the last 2 days?
And another thing that we hear is that this only affects the elderly or those with that already had underlying medical issues already, right? I mean, is there an age discrimination, or is there a segment of the population that this affects more than others, or is this something that younger people need to worry about as well?
Yeah, I would say that we do know that the disease is milder in younger people for the most part. But there are exceptions to those rules, and there are still children that have serious illnesses, underlying illnesses, chronic diseases. They can be hit severely by this. There have been deaths of young children, usually in that situation, though. In your teens and 20s, you're going to be hit by feel like you're hit by a freight truck, but you'll probably recover. You probably won't be hospitalized. But you start getting into your 30s and 40s, and even when you're healthy, there is a small percentage of those patients that get severely ill, still end up in the ICU, still end up hospitalized. Up until the Chinese data was kind of what came out first as far as mortality, and they divided it up by decades. And so the mortality rate is about 0.2% each decade all the way up until about age 40. And then it starts doubling every 10 years there. So between 40 and 50, your mortality is 0.4. Between 50 and 60, it's about 1.3. Then it jumps up into the 3 to 5 range. Then it's up into the 10 range. By the time you get up to over the age of 85, that mortality rate is almost 15%. And so it is dangerous to the elderly, but younger people do have a risk, and it only gets higher with age.
So we've talked about social distancing and why that's important, the droplets and such. I mean, I guess another big question is, should I be wearing a mask? If I'm going to the grocery store, should I wear a mask?
I think that's important, but even more important is knowing how to wear a mask. So, there's a lot of hygiene and behaviors that go along with wearing a mask in order for it to be effective and to do any good.
Right.
There's a lot of debate on the material and what to wear. And I would argue that, for going out in public, anything is better than nothing. But one thing you want to be looking for is something that's comfortable, that properly, completely fits over your nose and your mouth, and that you don't have to constantly be adjusting. The more you touch this area of your face in your mask, and the more you're adjusting it and moving it around and shifting it, you've basically just coughed all over your hands. And so then anything you touch after that is going to be a contaminated surface, and you could potentially be spreading it to others if you are in that 2-day window, or you're also bringing that exposure very close to the very area it needs to infect you. And if you don't have a real solid mask, a real effective mask, just by you adjusting it, you could be bringing droplets close enough that you could inhale them.
Right. So there's some, there's some miracle cure claims out there, right? Like this'll stop it. I mean, anything out there that medical science has said, yep, this is good.
There is no effective treatment out there right now. There are a number of drugs that are being looked at as contenders here, and I can tell you that despite what you might hear out there, nothing has been very promising so far. So the big one that's been making headlines lately has been the hydroxychloroquine or Plaquenil and azithromycin. Now, azithromycin is a antibiotic, and it probably is effective in some of these COVID patients just from the standpoint of treating a pneumonia that happens to them. But I don't know that it's going to be a cure-all or a prevention medicine. And Plaquenil is a immunosuppressant. It was originally developed for malaria treatment, and then it's expanded its usage into autoimmune diseases. And I have yet to actually see anybody propose how it actually helps or how it might protect you. So I think there have been a number of studies that have looked at it, and the studies that showed a positive benefit were really badly designed studies. And there are a lot of studies that show no improvement, and there are a lot of studies that show that it's got some potential risk and danger as well. So when you combine those two drugs, that azithromycin and Plaquenil, hydroxychloroquine, that can increase your risk of sudden heart arrhythmias that can be fatal. So you can effectively stop your heart by taking that combination of medicine. So if anybody out there is tempted to try and acquire this on their own and take it on their own, I highly recommend against it, because when we prescribe this for people, we are monitoring their heart. We are doing follow-up EKGs on them, and we are carefully dosing these medicines. And so this needs to be done under the guidance of a doctor and with specific reasons in mind. And there are a lot of pharmacies that are not even filling this because the evidence is so scant, and the risk is so high of these medications. So. And the other problem that's come about is that people there's a shortage of this medicine for the people that are actually needing this and are prescribed this. I've seen it in my own practice that patients that normally take it for the current recommendations aren't able to get it.
And this question, I even hesitate to ask it, but so we have some data now, right? Like, again, a month and a half ago, it was, is it even going to come to the United States? And now we have some data that says how many cases, how many fatalities. And now that data is being greatly questioned, right? Like the causes of death have been altered even, or there's presumed, now the latest thing was there's been some, presumed causes of death. Can you speak to that at all? I mean, I'd hate to ask you if you've been told to manipulate causes of death or anything like that, but has anybody at any level contacted you and said, hey, we really got to make this thing seem worse than it is. Let's alter our data or our findings or our reportings?
Well, there's a lot to that question. So let me pick it apart a little bit. First of all, you have to understand how death certificates are filled out normally in order to put this into context. Okay, so step one is when I'm filling out a death certificate, I often have to fill out something that identifies a chain of events for people. So there are often multiple causes listed on a death certificate that all add up to the final cause of death for people. And that's how we're encouraged to fill it out. And sometimes we know the precise chain of event. We have very accurate tests, and we have a very detailed medical record to look at, and we can precisely detail this out. But there are often times where somebody dies of natural causes in their own home, and we have very little to go on. We have very little testing. We have very little witnesses to what actually happened. And so we are trying our best making educated guesses. So a death certificate is not always 100% accurate to begin with. There are limitations to it, and whenever possible, the people keeping track of that do try and investigate it. I frequently get follow-up messages or phone calls that try and clarify, what did I mean when I filled this out, and is there more to the story that they need to put on the record. So that's part one to answer your question. The other part you have to realize is that in a national emergency of any kind, the rules do change typically, because the government agencies that are tracking this are doing it with an interest in both protecting people currently and also using that data for future planning for the next disaster. And so they do change the rules in these types of situations. A good example was when the hurricane struck Puerto Rico, and there was this a lot of controversy about that. And the fact of the matter is, a lot of people died, and not immediately during the hurricane, but they died afterwards. And those health officials were instructed to, whenever possible, if it was related to a complication caused by the hurricane, to list that as part of the record. Now, it's not saying that they died from the hurricane, but it's saying that that was a contributing factor. And I actually have some examples. So this gets to your real question. What were we instructed? Okay, there's no conspiracy to influence or inflate numbers, but there is a conspiracy, or I should just say a directive, not a conspiracy, but a directive to be as accurate as possible and to paint as accurate of a picture here. So maybe people will be able to see this. I'll try and hold this up here. But this is sort of an example of what a record looks like. It's probably reversed, actually, so it's probably not very effective. But
I got the gist of it. There was three different causes listed, right?
Yeah. So the first one was acute respiratory distress, and that is the primary cause of death for this patient in this example. Below that was listed pneumonia, and below that was listed COVID-19. And so that would be the chain of events that I'm talking about. So, in this case, they're saying, if a patient came into the hospital, tested positive for COVID, we have a documented test, and then they developed pneumonia as a complication of the COVID, and then ultimately developed acute respiratory distress syndrome and died from that. That's the chain of events. So that just factors into them calculating how many deaths did COVID have a role to play herein. Now, there's another example they use where instead of saying it's a clear positive test for COVID, it's a probable test. And we know that right now, influenza, I already spoke about, has dropped off dramatically. But if somebody were to present now with a viral illness and was having fevers and a cough, and then they had that same chain of events happen to them, and maybe they died at home, so we never got a test done in time. Or in New York City, maybe they've died. They have so many deaths that they can't accurately test everybody before they're buried. They're presuming that the most likely cause of death right now is COVID, because there's nothing else out there that would act like that at the moment. And so it's a probable COVID-related death. And again, the health officials do their best to track that down. They will follow up later with those patients and those providers, and those patients' doctor, and ask them if they, maybe got a test back later after the COVID or after the death certificate was filled out. So they're constantly trying to make that as accurate as possible and update the record whenever possible. But it's no inflation. It's just a very educated guess, and it's designed for the public health officials to document the spread of the disease, to track the spread of the disease, and to help us determine how effective our efforts here and how to prevent a future pandemic. And we've been acting this way for a long time, pretty much since death certificates have been invented. this has been one of the purposes and uses of it. So this is not new. This is not a conspiracy. This is normal operations in a very difficult environment with limited testing and widespread a fast-acting disease.
All right, I really appreciate you taking time, Dr. Hess, and I have just a couple more questions. So, non-COVID health issues, right? Let's say I have a how would Tri-County Healthcare like me to address my non-COVID related health issues? What advice would you have for that?
That's a great question. So one of the things we've done in the last month is worked on isolating and separating out our patient workflow so that if you don't have any respiratory illness symptoms and you're trying to come in for routine health care, we have designed a way to protect you so you're not sitting in a waiting room next to somebody who's coughing or next to somebody who has a fever. We have set up specific clinics just for what are our non-respiratory illness patients. So there's a screener at the door that checks you in, asks you about symptoms, provides you a mask just in the off chance that you're one of those people that's asymptomatic in the first 48 hours. And then we try and minimize, your waiting room time. We try and get you right into a room. And we're really running a half schedule right now so that people can be separated as much as they can in the building. If you do have a respiratory illness, we have a specific area we're going to send you for any kind of a follow-up. So let's say, you have a sore throat and you think it might be strep. Well, we don't know. Strep or sore throats can also come with COVID. And so we're going to treat you in an area and protect you and other patients and staff like you might have COVID until we find out otherwise. And so we're going to have you get care in that respiratory care area where you can be protected, where the staff can be protected, and is wearing an additional layer of, the personal protective equipment. But we're not trying to keep people from getting medical care because delaying things can be just as dangerous. You don't want to try and put off a problem for a month and then come in and actually need to be hospitalized in the middle of this surge when we're taking care of all these COVID patients. So I still encourage people, if you have health needs, call the clinic, talk to them, tell them what's going on. We will help find out what you're coming in for and direct you to the right location. So, I hear a lot of people saying, well, we're shut down. No, we're operating differently, but we're not shut down, and we still need to take care of people, and we still need to do what we can, and we're doing what we can to minimize your coming into the building as well. So we might be delaying labs, we might be delaying x-rays that can wait a month or two, we might be refilling your medicines for a month or two right now, and hopefully, that'll buy everybody a little bit of time. So we're not making you come in for silly reasons, and we're doing what we can over the phone as much as we can, but some people still need to be seen face to face. They still have ankle sprains. They still need stitches. They still need all this other stuff, and that's what we're there for.
Any final thoughts? We've talked about a lot of things, but do you have any closing thoughts or anything that you want to make sure that people know about the situation?
Sure. I think it really gets back to a lot of the questions on people's mind are the social distancing and the preventing the spread, and these mitigation efforts are working. We are actually slowing down the spread, and we're delaying the spread, and we're buying everybody time, and that's what we're trying. That's the most important thing here. But we can't get complacent, and we can't get lazy about it, and we can't just shrug it off as it's not needed because there's no cases in the community. Because I assure you, as soon as we start doing that and we stop the social distancing and stop the good hand washing, we're going to start seeing flare-ups. That happens every pandemic. There is the initial big surge, and then people think it's gone, and then there's down the road there's a second wave and a third wave and a fourth wave, and those are just as dangerous and just as deadly. So we have to keep operating in a safe way for as long as we can. And there's going to be, a lot of discussion about the economics of that, and that's not my area of expertise. I'm not going to pretend to comment on that, but medically, we know this is not going to go away anytime soon, and a vaccine is at best a year and a half out, probably longer. So we have to figure out how to operate in this new world in a safe way for everybody.
All right. Well, thanks again for taking the time. Keep up the good work, and thanks for showing us that we can be better together.
Thank you.